First of all, a big welcome to everybody. So this is our GCR Radiotherapy Essential Standards in Cancer Plan webinar, the second one. Remember, our aim is to create a framework of key components for radiotherapy that should be considered when either developing or updating a national cancer plan. If you remember, we had phase one a few weeks ago. That brought together a wonderful group of panelists: WHO, City Cancer Challenge, experts in cancer plans and low and middle income countries. Mary Gaspardarovich, as you know, was our moderator to phase one. Unfortunately, Air Canada changed her flight, so she couldn't moderate this one, so I'm her stand-in, but she will obviously be sent the video. She's very much involved with this, and hopefully then she'll take back in control of the third one. And she sends her best. So this is our second workshop, and we've really broken this one down into key components that we will develop with our expert panelists from around the world and bring industry to the table today. So we're excited to hear from our panelists. They have been, their CVs have been sent, so hopefully you know all about them, and we want your input from yourselves. And as I say, if you could use the chat, and we can then, that's where we can all share ideas. So great. So I'll now turn over to Darian to discuss this phase two.
Thank you, Pat, and thank you all for coming and participating, and a special thank you to our panelists who have prepared today. And as you can see on the screen, we have phase one, which Pat just went through, and now phase two is where we're at. We're addressing 5 key components of the framework today. And as you saw on the agenda, we've asked experts to the table for these components. The outcome of this is that we are creating a framework of these components. We're getting together working groups, so we'd like all of you to join these working groups throughout the meeting. If you find one of these components is essential for you, you're an expert in this area, you have things to contribute, please put in the chat that you'd like to join a working group. We want it to be a multidisciplinary team. We want everyone at the table. And this is what's so wonderful about the GCR. We have this lovely global network of individuals who have so much to share and so much expertise in these different niche areas that bring together what radiotherapy truly is. And then we will be assigning a group lead, or you can come forward and request to be a group lead. We would love that. It's not a huge responsibility. It's more about communication, making sure that we initiate and follow up before phase 3. We'll have the summer months from June until August to create a digital document. So the wonderful technology that we've all brought us together from around the world, we're going to be using some Google documents to create these frameworks, and it will be essentially broken up into 3 parts. The essentials, which is what we're discussing today. What are the essentials for your component? We originally thought about this as developing some minimum standards, but the reality is we don't want minimum standards. We want to know what is essential to create radiotherapy in cancer plans around the world. And then it will be a checklist after that. A very easy resource where anyone, even outside of the radiotherapy community, could come in and say, all right, here's the checklist that I need to ensure that I have the essentials for training and technical support within my radiotherapy plan. And then finally, a section on implementation, which will really develop during phase 3. The costs, the implementation with government and ministries of health, all of that. So we'll talk about that a little bit more at the end of the meeting. But now I'm going to pass it off to our lovely panelists. We'll start first with the training and technical support, and that will be Michelle Leach from Trinity College Dublin.
So it's a pleasure to be here today and to talk about, I suppose, a topic that's very close to my heart and also to my colleague's heart, Mary Coffey, and we're doing a little bit of a duo on this. But just to start off, I guess one of the most overlooked issues in the development of cancer service and cancer plans is the education and training of staff who are actually required to deliver this service. And Mary and I are radiation therapists by profession. So in the next few minutes, we're going to give some insight as to the consequences of not putting sufficient emphasis and resources into the education and training needs of radiation therapists specifically, as that's our profession, into national cancer plans. So I'm sure, as most of you know, and I've seen in the chat, there are quite a lot of radiation therapists with us today, that we are the professionals within the radiation oncology team who plan and deliver radiation therapy, and as well as looking after the side effects of patients and the psychosocial management of the patient, which is equally as important. If you like, we like to consider ourselves as the gatekeepers of radiation therapy delivery, because the difference between correct and incorrect delivery of treatment really lies in our hands. And that places the responsibility between planned or anticipated treatment outcomes and actual treatment outcomes with us. But however, despite this really enormous responsibility, the standard of education and training of radiation therapists globally is really highly heterogeneous, ranging from dedicated radiation therapy specific undergraduate degree programs of up to 4 years in duration, to the complete opposite end of the spectrum, so no formal education whatsoever, with just some, if you want to call it, on-the-job training, just specifically on how to use the equipment. And in this latter scenario, this means that the scientific underpinning of radiation therapy practice is completely lacking, with little or no understanding of the damage that can be caused to citizens by the incorrect preparation and or delivery of radiation therapy. And I think, Mary, you're going to take it up from me there at this point. Thank you.
In addition to that, I suppose we have to look at safety and radiation protection. And radiotherapy is changing so dynamically in terms of technology and techniques, with very high doses per fraction, very high total doses, new ways of approaching coming continuously. And for me, if we look at that and we look at the promotion of a safety culture within a department, that's impossible unless the people actually delivering the radiotherapy understand what a high risk area they're working in. And I think if you want a safety culture, then you have to engender people that they are constantly aware that everything they do has potential hazard for the patients they're treating. And I don't believe that you can expect that of people who have no background, no education, no knowledge, no skills in the area. And I know that there are a lot of resource issues, but I think until we address that, at least there is a minimum core content that enables people to understand what happens when they turn on a treatment beam or when they prepare for treatment. They cannot understand the risk they're putting patients at. So whatever the resources in the country, whatever they have available to them, there has to be sufficient core pure radiotherapy knowledge if you really want them to be safe and deliver quality treatment to everybody. And you'll find, I mean, I've been in a lot of centers where they're very kind, very well-meaning therapists, but they are really treating patients badly. And it's only because they have no idea of the consequences of what they're doing. So I think that's my message today.
Thank you both, Mary and Michelle. Very important messages. We'll now turn it over to Antoine.
Hello, everyone. And first, I'd like to thank the GCR to give us the opportunity to talk about these important topics. As just discussed, it's very important to get a staff fully trained. But as we know in radiotherapy, what is critical is continuity of treatment. Radiotherapy, we have treatment with multiple fractions that are optimized to give the ideal dose to the patient, and the timing of this fraction is very crucial. So this radiotherapy is really sensitive to any interruption, breakdowns of the systems that could really impact at the end the quality of treatment and the outcome of what we'll have. So in order to make sure that we give the best continuity of treatment, we need to put in place a correct maintenance and service. So just for everyone to what definition we give to maintenance and service, the maintenance will be everything that will be made periodically to prevent any breakdown, to minimize the breakdowns on the system. And the service will be really the reactive process to put back on the system backup when any issue is happening. So when we come to talk about what would be the ideal cancer plan, we should really make sure that we take into consideration the maintenance service costs, what it includes. And for this, there is three main pillars that we see. The manpower we need to have. So basically, it takes the right person with the parts to be replaced when there is a breakdown with the right knowledge. So the right person should be the people with in the right location, close by to the hospital, with a proper background to be trained on the systems. And they need at least to be two, at least for the first system, to make sure that there is a backup. And regarding the spare parts, also we need to make sure that we have the right approach. In some countries, Marcus will talk about it, when there is custom clearance, we need to make sure that the right parts are accessible, because if you have the right engineer, but he doesn't have the parts, you won't be able to fix the system. And next topic is training and education of our engineer, but I will pass over to Marcus. And sorry, I'm a bit over time.
We expected that, right, Antoine?
Yes.
So, grüezi miteinander. I'm Marcus. I'm working for Varian for more than 20 years in the service department. And actually, we are fully in line with Antoine just said. We have the same troubles. At Varian, we have about 3,000 machines installed in Europe, Middle East, and Africa. Some of them in very comfortable and easy accessible, nice places, right? But some of them are also in less easy to reach and to serve and to maintain areas. It has been discussed in the phase one of this panel discussion, the lack of know-how and the missing training. And these are for sure all the main issues we have, basically in terms of available biomed engineers, electrical engineers, finding proper staff, right? Other than that, it's also the political situation, the political stability, a working healthcare system, and the country's strategic plan to align the screening, so the diagnosis, with the final treatment, and the proper reimbursement scheme. So considering really the desirable standard treatments and not just the bare minimum ones, are all the bottlenecks we are facing in many of these countries. Not to speak about custom clearance, as Antoine just mentioned, where it takes us sometimes weeks to get a part cleared through customs. But unfortunately, and very often, we do struggle with supposedly much easier things, such as simple stable power situation, or working aircon, working chiller. Internet access, very important these days, is our high tech. We do have the data, but if we don't get the data out, we cannot do a proactive service, right? Or, unfortunately, simply the understanding of cleanness. Our high-tech machines need to be up and running, simple supporting systems. And in here, we learned, often the hard way, that we have to find local, suitable, and sustainable solutions, which can be installed in the respective area, but also maintained, and overall, a system uptime can be granted. Well, I guess we're looking forward for this upcoming discussions, and thanks for the moment.
Welcome, Caroline.
Yes. Thank you so much. I struggled to find the link, so I was slightly delayed. So thank you. Thank you for inviting me, and pleasure to meet you. It's the first time here on this call, so very nice to be here, and thank you for the invitation. So I am Caroline Cook. I am a board member of Electa, and I have an initiative I'm working on, the commercialization of our software from a strategic and business development perspective. So we're talking about data monitoring today, and I have about probably 4 minutes. I'm going to keep it quite short, but what we are seeing at the moment are some key trends in the market, where we are looking at more of 5 different trends when it comes to the impact of software within oncology. And the first one is more around interoperability, where the open data ecosystem requires a new standardization of how data is interoperable with other systems. We have a new kind of segment of people we're talking to as an ecosystem, which is CIOs in hospitals, especially in the US and Europe. We are also more connected to EMRs than than we probably are at the moment, or we should be more connected to EMRs in our countries. And obviously what happens is that this increases a lot of fragmentation in the market. And it's something that we as an industry should really think about. How do we play within this ecosystem of different providers that has a really important role, including in our field, but a really important role in how we take care of our patients and the outcome of patients and how we treat better. So interoperability is one of the key areas where we as a industry should really think about how we play within that ecosystem. Then we have capacity constraints. I mean, you're more aware of this than I am, and what that means to the industry and the caregivers. And on the third point, care has become much more complex, where patient centricity is the key, absolute key thing we should start with and end with when it comes to how we're thinking within this industry, especially as a supplier. Then, of course, payment models are changing. We are looking more about the growth into value-based payment models. That's going to change going forward. And the payment models are all obviously a very important indicator how reimbursement is done. So really looking at these reimbursement models will pan the way forward. And then obviously we have data utilization and monitoring, and this is obviously going beyond data harvesting, more into more federated insights generation. And I think as a responsibility for us for patient outcome, we should really look at how can we as an industry look at data more effectively for insight into patient outcome, but also as a very heavyweight kind of data source as we are, how do we use that better and share and benchmark amongst us with the one common goal for better patient outcome? And I think here is a real, we have a lot of barriers to overcome here in terms of sharing data, but data utilization and monitoring comes with one point in mind, and is for the patient and for better outcome, better treatment option. And here we can really work as an ecosystem together to improve that. So that's in terms of trends, but obviously the frictions in the market is what we can have solved. And just for 30 more seconds, I think improving data interoperability within the ecosystem is one priority we should look at together, potentially for better outcome. We should look at capacity constraints and how we can help them together. We should look at data utilization, how we can improve better patient outcome, and see how we can utilize and monitor that data for insights as well. So what I'd say is better for a better outcome, better patient outcome. How do we monitor this data together within the ecosystem, and not only for us, but also for EMR players and even big tech players to really come together and improve what we're doing with the big source of data that we have. That's everything for me, and I'll stop there.
It's a pleasure to be here and to join in the conversation. I'm a radiation oncologist, health services researcher involved in the Ontario Cancer System as the quality lead of the radiation program. So a lot of important themes have been brought up by Caroline. I'll ask the question first: why do we want this data? And I think that helps to understand what is truly essential for data monitoring and data standards. And understanding that access, quality, and value are central to how this data will be used and how we want to improve these aspects of care. We can think about specific elements that could be a part of an essential standard. I think considering access, quality, and value, access is probably an especially important one to consider, as we do already have some really important information on value from the Lancet Global Commission on Radiation, but we need to have the appropriate equipment in place before we can even consider the quality of care. So thinking about access to the right equipment and personnel, we need data that cover a supply target, very specifically histology, topography, and date of diagnosis. We need to know if someone has had radiation or not, and then details about machine throughput and actual machine and staff numbers that currently exist in each jurisdiction for volume forecasting. In terms of quality, we need radiation data that's fairly simple, and that can go a long way, and it certainly has in Ontario and other jurisdictions. We need patient-level dose fractionation information, site modality, and date of diagnosis and treatment, and that can be incredibly powerful, especially if we have it on the patient level. We need information on safety, and a common platform and nomenclature is very important. And of course, some data will just need to come from surveys rather than detailed health administrative data. An existing international standard should be adopted and considered when we're thinking about data. And also really important to think about a budget for data. We need an IT budget and data management capacity built in to whatever budget planning that we're doing. Some aspects of essential data can be resource stratified. For example, the degree of coverage of the data, whether we're talking about a high quality institutional data source or population-based registries that cover regions or a whole country. Also, the frequency of specific radiation data collection can be resource stratified. And I think just in terms of success with essential data, I think using the data together through an international community of practice with specific benchmarkings or shared projects could go a long way. So I'll stop there and look forward to the conversation.
So I am Sarah, I'm the Director of Radiotherapy UK. And just in talking about advocacy, we are currently running 2 campaigns which dovetail into each other. We've got the Radiotherapy for Life campaign, where we are looking at increasing investment in radiotherapy to improve equality of access to high quality radiotherapy in the UK. And we also run a campaign called Catch Up with Cancer, which raises awareness of our current record waiting lists for treatment for cancer patients and the need for there to be an urgent change in direction regarding policy around cancer treatment. And also within that then how radiotherapy offers significant solutions to the cancer wait lists. And I suppose in terms of cancer plans, it is really important that we advocate really strongly for cancer patients and for achieving the best outcomes for these patients. And I suppose whenever I think about this, and I've been advocating for patients for the past 15 years, what's really important is to first think about being very clear about your aims. What is it that you want to improve? Is it one specific area? Is it about introducing a new technology or a new treatment? Or is it wider than that? Is it about aiming for world-class radiotherapy? Now, it can be all 3 of those things, but it's good to be an idea of kind of what the steps are along to achieving that and what's realistic as well. And then it's about amplifying the voices of those who are directly impacted by this. So why is it needed? And what's so important about this is giving that voice to the patients and to the workforce and allowing them to speak, giving them the platform to speak, because they will have the most compelling reasons as to why you would want to change policy or invest in a certain way. And then within that, we look at it like it's by creating a movement. You want to bring everybody with you, and it's very, very collaborative. So you're looking for the supportive politicians, the ones who understand it, who get it, who maybe have people in their constituency who are really struggling with access. For us, it's to radiotherapy. You're looking for bringing on board the professional organizations, the industry, the patients, and the workforce, and engaging with everybody and making sure that your key messages are very, very clear, and then supporting and amplifying these groups to work with you to deliver on those key messages. And before I hand over to Shandy, I suppose the one thing I would say within this is to advocate well, you need to be incredibly agile. Goalposts are always moving in the world of policy. Policies change regularly, politicians change regularly, And we all know that governments change as well. So you need to be able to move, adapt, and work within the environment that you're currently operating in. But if you're amplifying the voices of the key people who are impacted by it, and you have some key messages, that makes the moving and the agility that's required so much easier. So I'll just hand over to Shandy now.
You know, we've seen a lot in our UK work as an example of how collaboration is critical to success. Having a unified voice from all of the stakeholders very much leads to success. Without that, you leave the government leaders to find it for themselves, and that doesn't always lead to the results that you want. And we've seen a lot of success with that in the UK. I think at one example, actually tomorrow, Sarah and Pat Price and I, as well as tomorrow morning, we have a meeting with a special advisor for the Secretary of State. So I will be representing industry, Sarah, the charity, Pat, all the things. Pat always represents all the things. She's our unicorn advocate, and together we can represent the entire community, and we will be more successful when we do that, because many of the things that we want to achieve require government officials to be a part of that conversation, and we need their support in order to move forward. And so without an advocacy strategy, we will likely not be successful. And so ensuring that is part of the advocacy plan, or excuse me, the cancer plans framework is critical, because we need them from the government officials from the beginning. So I think, you know, ensuring that there is a regular drumbeat of meetings with government officials. I know sometimes it's once a year, sometimes it's twice a year, depending on the cadence that you can set up with your particular government that you're working with. Having a regular cadence of meeting with them, the government officials, allows them to really engage with you and know who to contact when they have questions, when things come up. So it really becomes a relationship that you develop, and it can take time to do that, but establishing that goal from the very beginning to bring government officials along with you on your journey of establishing a cancer plan is really critical. And we are excited with our UK work to see hopefully some successes with that tomorrow. I think you know, it's a pretty big meeting, and it's just been really amazing to see how bringing government officials along for the ride from the beginning, and finding those champions who will bring up your issue area in meetings you may not even think about, but they, you know, if you have a relationship with them, they think of you and they say, oh, what about radiotherapy? We need to make sure we include them. And I think that's something I've seen in the US, and we've seen it in the UK and other countries, that if we don't have a voice in the room, we are forgotten. And ensuring that we establish those relationships from the very beginning of cancer frameworks, then we can, you know, they will not be able to forget us. And so anyways, I'll close there. Thank you.
So I'm not going to share again. I'll just, you know, take you through within a few minutes. So mentioning quality and safety, which is a very important component of what we do. Of course, we know that radiotherapy is very crucial modality for us in cancer management. But quality in itself, it's a standard and effectiveness of treatment. In terms of the importance of quality, we are looking at patient well-being. We are looking at treatment efficacy. You're looking at protection of personnel. And these are three components that whenever we talk about quality, we focus on. And for us as professionals, radiation therapists, oncologists, physicists, it's very important for us. But quality assurance is usually a systematic approach. So you need to be able to have a program for it. And the program is supposed to ensure that treatment is accurate and consistent. So as much as you have the quality assurance, you are looking at treatment accuracy, and you're looking at the consistency of whatever you're doing. What are some of the components of the quality assurance that we are looking at? Regular equipment calibration. We know that, particularly in our setting, we need to be able to ensure that there's always equipment calibration. We are also always able to ensure that accurate and consistent radiation is delivered to the target where we want to treat, and then precise delineation of targets and areas that are at risk. Impact of standard. In terms of that, we're looking at optimization of treatment plans, and then the treatment delivery verifications as well. But what are some of the solutions that we want to resolve? For us in Africa, and I speak about Africa because of where I find myself, we need to ensure, prescribed doses are appropriate and safe for patients. We do quite a number of treatment fractionations, and sometimes, what we have is LINAC and cobalt, so how does the fractionation, impact, these things? And then the treatment delivery checks by pre-treatment verifications are also very crucial for us. Prompt identification and resolutions of issues to prevent potential harm to patient and the staff. These are things that I believe, we can look at. And finally, looking at staff safety. What do we do? Personal protective equipment we use, but sometimes we as staff, we tend to forget, and by the time we realize we're going in and out of the radiation room without wearing anything. I see clinicians coming inside the treatment room, nothing, they have nothing on them. But these are things that we need to look at, and radiation monitoring and dosimetry is also essential. I think I'll end here. I'm sure training education has been handled by Michelle and co. Thank you so much.
Thank you, Darren, and thank you so much to the panel. That was amazing. So top level I got from that is that it's only us as a community that can define these essential standards. We know what we're doing and we have to do it. I think there was such incredible detail that in all different areas. And what really came through to me is that it has to be all stakeholders, patients, workforce, and industry, because it's really patients, workforce, and technology, really. And I can see how bringing all that together and then learning internationally from each other could be so powerful. But there is quite a lot to do, but it's absolutely doable. I thought this was fantastic. So perhaps if I could first ask Michelle and Mary. So I suppose my question to you is, what are the key steps in setting the standards for training and the quality in practice? Just, we can obviously work on this, but just off the top of your head to get some other ideas.
Yeah, well, will I start, Mary?
Yeah, you start, far ahead.
Yeah, I suppose that, Pat, the main thing that we have found is that you really need to have a desirable standard. It starts really with a curriculum, and also with buy-in, I suppose, to a curriculum. And we've run some recent data that's in the process of being published, but that really shows that one of the major barriers, of course, to incorporating curricula is a lack of buy-in from stakeholders, and those stakeholders being governments, ministries of health and education, who don't understand necessarily the importance of education of radiation therapists. Probably a lot of it, I think we have to put our hands up. A lot of it is because, we're not a well-known, modality, unfortunately, despite everyone's best efforts. And I don't think that the impact of the lack of education at that level of radiation therapists at that level is well understood by people. So people go to the hospital, they expect they're going to be treated by people who are highly educated. I mean, it doesn't cross their mind that they're not, and that's their expectation. So therefore, it can come as quite a shock to people that this is an issue. But I think a curriculum that has buy-in from everyone, and that is radiation therapy specific. And that has been a huge issue for us for many years. And I'll hand over to Mary now in a minute. But we have a lot of combined programs where really, we have found the percentage of radiation therapy specific education in those programs is probably somewhere between 5 to 10%, if you're lucky, and therefore we're expecting as Mary said earlier, these very well-meaning radiation therapists to come and treat patients, and really who can do that with that level of knowledge. So Mary, I'll pass over to you to carry on the chat.
Yeah, well, I suppose for me, there's a lot of complacency in terms of the need to educate radiation therapists, because there's the sort of conception that the radiation oncologist has really good prescription, and that the prescription is excellent, that the physicists make sure that the machines are delivering the right dose, that their quality is good. And they seem to think then that nothing matters after that. But in the end of the day, it's the person who puts the patient on the table and actually delivers the treatment that can do the most harm. And that is ignored quite widely by, and sadly, by our own professional colleagues, by whatever group is in charge of radiotherapy education in the country, be it under a diagnostic umbrella, be it under a nursing umbrella, be it under an engineering umbrella. They don't see that the radiotherapy component is important. And there's a lot of talk on radiation protection and knowing about the kind of impact of small dose and that sort of thing. But nobody considers that for really to treat patients well, you need to understand the interaction of tissue and radiation at that energy, because what you're trying to do is not overdose normal tissue. But if you don't understand what happens when you do it, then you can't be expected to do it correctly. So
that's really important, and I don't know in other places, certainly in the UK, it's more than 50% of the radiotherapy workforce. You know, it's mad if it's not being prioritised. And I certainly find, as a radiation oncologist now, over the years, technology has whizzed on so much. I'm so much more dependent on the radiation technologists than I used to be. You know, when we did our own hand planning years ago.
As I have done myself in the past.
But this is so important, and I think it's exactly, it's so important going forward. That's great. Can I just move on quickly to, and people do put chats in, because we're throwing around ideas here, maintenance and safety. I was very struck again by the ability of power and stability. When you think of our Ukraine Radiotherapy Task Force, their biggest problem actually recently was the generators going and that type of thing, and all that sort of thing. And it's so important that we don't neglect this safety and maintenance. I was just wondering whether there are opportunities for remote monitoring of radiotherapy equipment. Is that be a really good way forward? Antoine and Marcus, what's your thinking?
Marcus, do you want to start?
Sure. I think here the industry have made big progress in the last years. And the newer devices, newer machines, they are super capable. We are creating massives of data, which we are also start analyzing properly. So only now we have the data, but now we start understanding the data. That's the other problem, right? Everybody has the same. In here, we have to say they have to allow us to win. Quite often we are seeing restriction in exporting data, so having remote access to the machines in these countries. Some of the countries will not allow us at all, and in others we simply have not the stability in the access in the 5G environment or whatsoever, right? Whatever you're going to use. So from that point of view, I think the technology made a big jump. We are much able to transfer from a reactive into a proactive service, but they have to let us win, right? We need the circumstances.
Yes. You need to. I fully agree with you, Marcus, and you really need to put this in the context of cybersecurity, where there is more and more threats, especially to our hospitals that are attacked, and so they really are trying to protect themselves as much as possible. So it's often difficult to get a proper connection to their system because of their local IT policy. But still, remotes, especially with the COVID time, we've been able to work more and more remotely, and is allowing us to proactively detecting issue, so monitoring our install base of system and prevent issue to appear, and also to connect remotely to systems to fix database issue or or even fix system remotely that will allow a fast recovery of the system for treatment.
Now, yes, and as you were saying, it's almost, this has to be upfront and named in these radiotherapy plans. It's not an afterthought and by the way, like, you know, get a maintenance contract. This is going to be really upfront of the complexity. I was just wondering whether, in terms of, you mentioned about getting local support, which I think, especially in lower income countries, is there any support there for, say, regional training hubs or engineers that can move around? Because it almost has to be that set up, doesn't it? Otherwise, the whole thing can break down, can't it? Anton, Marcus, any thoughts?
Yes, I'll start with this one. Yes, especially we are in a moving world, and for example, right now we have the issue of more and more countries that cannot travel abroad. If we take the example of, for example, Russia cannot, our Russian technician cannot travel anywhere, so we need to find solutions. Again, COVID was a great opportunity to learn. We completely switched our training systems from all live trainings to hybrids, a mix of e-learning and some validation on site, but with as much as possible limit of validation. For sites, for countries where we cannot ask people to travel, we try at the maximum either to go there with our own trainer or try to go in, let's say, neutral area in some of the other countries where both can travel, and we will organize the training there.
Yeah, I agree with Anton, definitely.
It's great, and it strikes me so important. Yeah, no, great. No, and thank you for that. That's something we need to really consider this. Can I just move on now to the data and monitoring? Caroline, Tim, really important points made there. And it struck me that if we can do this globally, as you say, into the insights, not everybody reinventing the wheel. There's a huge amount of sharing, isn't there? Because it seems to be that could be one of our, in terms of, as you say, access, quality and value based, it's our data that's important. So I was just wondering if you have any thoughts on what practical solutions are there, so when we get these essential standard, and do we need a setup globally so it is accepted, it is shared? I know the UK, we had our radiotherapy data set, so off the machines the data was collected. We sort of pioneered that years ago. It must have been 20 years ago we started that. Now, how can we get all that technology that's there to use it globally and have it sharing it all? What's your thinking? Tim, Caroline.
Caroline, do you want to start?
Tim, feel free to start.
Oh, sure. There was a bit of bad connection there, but I'll answer what I think I heard. I think that number one, having an accepted global standard of data is crucial. I think getting radiotherapy data in and combining it with basic cancer registry data is one important part of linkage, and thinking of ways to capture that all within the radiation system could simplify. I think working together to common goals, common projects internationally, benchmarking of radiation utilization or specific quality indicators like waiting times could really rally people together to work on this. And I think, again, the investment in people so that you can pull this off, it does take time and effort.
Yeah, I totally agree with Tim. And I think like what Tim was alluding to is the operational data that comes out of the machines. How quickly are we treating, time to treatment, what's the outcome of the treatment, and linking that together. And that benchmark data is extremely valuable to cross-reference against, for people to understand what does good look like. And when we know what good looks like, we could really start an overarching training schedule that can go nationwide. I mean, I live in London. I'm part of NHS. I'm a patient of NHS. I would love to know what good looks like if I'm a cancer patient. patient, and that should be open, it should be transparent. And that's where I think we as thought leader with the medical oncology space could really come out and say, this is what good looks like. And that's, I think, the way to share data amongst an ecosystem between us, as suppliers potentially, but also professionals and people that are part of this big space.
That's important, and that'll need a bit of work to make sure that that's a reality. But I think that's a very good in with general cancer plans, linking with cancer registries, all these sort of things in the whole cancer plan. It gives radiotherapy a space and a need. Great, we need absolutely more of this. I'm conscious of time. I just wanted to talk a little, some questions have come through about quality and safety. And I just wondered, Kofi, whether is there a problem in lower middle income countries with the standards which are affecting people's usage and recruitment where you are?
Yeah, in terms of equipment, we in our developing countries, we have to do with what we have, particularly with the kind of equipment we have. Some few years back in Ghana, we just had a cobalt, which was donated by the Chinese, and we had to use it for years before we had to migrate, to get, Linux. And many places within Africa, they just have to rely on just one machine. And sometimes with, quality, you have to struggle with it. And it's not that easy, but we do with what we have, and the training we give out, we try to, assist as much as we can. But you can imagine if the need is not there, the machines are not there, the kind of things that we need to use, for quality of work, we don't have it. So that is where the problem is. But I can tell you that we're doing what we can within the resource that we have, and that is, and so it's challenging to be working within the sector, but I believe that things will get better with time.
And so just finally onto the advocacy group. So thank you for that. So other countries there, how can we, I know the GCR has done an advocacy toolkit. How can we perhaps incorporate that into plans as advocacy needs to be part of it? Does it need to be overt? But some great messages in there, a voice in the room, because that's really our problem with cancer plans, is radiotherapy as an appendix as the back rather than that. So Sarah and Shandy, any thoughts on what practical steps could be taken within a radiotherapy plan?
Yeah, I think working in this type of global context as well is incredibly helpful for individual countries, because if you can speak to this is what's happening globally, then it makes your argument so much more compelling and more effective. Even currently we're looking at that with international comparisons and where the UK is lagging behind, and where cancer patients are benefiting from advances in radiotherapy that they're not benefiting from in the UK. And that's always quite a good start. But if there was within this agreed common goals, common targets, there's a piece around advocacy and there's a piece around what that looks like, that gives a blueprint for those countries to say, well, look, this is what other countries are developing, this is what we need to. So I think looking at it in the global context is incredibly important, because it raises it up into the, into everything else we're talking about, the data monitoring, the workforce training, sustainability, all those are incredibly important. But not if people who are making the decisions don't know about them, and the people who have the funding. So it just needs to work seamlessly together for a cancer plan to actually have the impact and the potential to deliver for cancer patients.
No, that's good. And Shandy, can I bring you in here? Because in terms of industry's role, I can see how absolutely crucial it has been having a trade body representation like AdvoMed or other centres that do there as a sort of a neutral in terms of bringing all the people together. And I know, Caroline, you were mentioning about you know, vendors wanting to play on the same grounds, because everybody it's a small world. And I know there are thinking, Shandy, tell us the role, because as I see it, sort of that neutral in there, and that can then bring out to the trade and bring those to the table together. How have you found that? Because it's obviously it's something like Advocacy is vitally important in all this.
Yeah, I think in my experience, both lobbying in the US and now working in other countries, I think that government officials tend to have a bit of a barrier up when they know that they're talking to a corporation, and they feel that there may be, you know, kind of a secondary agenda, not the greater good first. And I think that having something like AdvoMed allows that barrier to come down a bit, to have much more direct conversations, kind of a more team sport appeal to the conversation and to the end goals. And I think that's it also takes a step out of the work of government officials. Oftentimes, so what, you know, we find consensus among these major competitors on the AdvoMed side of things, and then present the unified voice of the industry. And I think that not having to manage that from the government's perspective is much more helpful than having to, it's one less voice in the room, one less chef in the kitchen, if you will, so that we can, you know, kind of tear down those barriers a bit, and have a much more cohesive conversation. And I think it presents a less self-serving face to the government.
Yeah, that's really important. That's great. And just finally then, before we wrap up, and everybody please do keep talking, we'll be back to you. I just wanted to bring in Birgit here, because I think you had a little bit of feedback and share a bit about the indicators quality conversation you had at the World Health Assembly and ESTRO meeting. Tell us, because that will lead us into what our next meetings will be as well. Sorry,
thank you, Pat, and thank you, everyone. I actually just included what you're referencing in the chat because I wasn't sure if there would be enough time. But having attended 2 sessions recently, part of which was with the Lancet Oncology Commission and another around quality indicators for cancer, overall cancer treatment, from surgery to immunotherapy, chemotherapy, and radiation therapy. And you know, everything that's being discussed here is absolutely critical and is a valid, valuable part of any cancer plan. I think what's very hard and which was shocking for me is that within the EU, just the EU, the 27 EU member states, only 12 have an updated cancer plan, and no visibility on whether radiation therapy is even referenced in those 12 cancer plans, and if the radiation therapy component is adequate. So I think there's an element of making sure radiation therapy is included. There's also just a really critical element of making sure cancer plans are in place. You know, Tim, you said very importantly, why do we need a plan? I think, you know, every country will have a different need for cancer plans, and whether, you know, service is the most important or data is the most important. But the essential standards we are putting together here ought to be a baseline framework for all of those plans. And then you can emphasize within those, depending on your country and the environment you're working in and the resource needs, what that plan should focus on. And without that, you're not going to have the advocacy, you're not going to have the funding. So it's absolutely critical, and we're doing absolutely the right thing, and there's a lot to be done.
That's great, and basically there's a lot to be done. Time is against us. Thank you so much, Darian. I'll let you wrap up the last minute.
Thank you so much, and thank you to everyone for contributing. I just wanted to share really quickly next steps as a reminder. We'd love for you to join us to be part of these working groups. The work is starting here. We will work on it throughout the summer months. contributing to a digital working document. The recording and the chat and notes of this meeting will be delivered to everyone, all those who registered. We actually had 150 register, and we know that this is a difficult time for everyone around the globe to gather. So that's why we do these recordings. So we'll get that to everyone. And then please save the date. You can register right away for our phase 3 roundtable, which will be on the 12th of September. And we're looking forward to as well being in person in London for London Global Cancer Week in November. So we'll send that date out to everyone as well. Thank you all for attending and for your wonderful contributions and this excellent discussion.